As a graduating senior resident, one of the experiences I looked forward to the most was the annual AAN meeting.
This is Dr. Sammita Satyanarayan, one of the neurology chiefs at Stanford, and a future neuroimmunology fellow at Mount Sinai, who joined me for today's program via Skype.
I will say that I'm a Midwesterner probably more than anything at heart. I'm from Minnesota, so that's kind of where I truly feel like I'm from.
Today, Dr. Satyanarayan is wearing her Stanford co-education co-chief hat. And just to backtrack, she reached out to me a few weeks ago to share how she and her colleagues at Stanford have adapted to the canceled AAN annual meeting.
Stanford has had a really long-standing tradition of sending all of its senior residents to AAN every year. Not only is it a fantastic education and networking opportunity before we launch into the rest of our careers, but it's actually a really wonderful bonding experience as well.
Because none of us were able to enjoy this year's AAN annual meeting, Dr. Sammita Satyanarayan wanted to celebrate some major neurologic advances from the year 2019 on our podcast.
To everything that's coming up that's new in neurology and sort of how we will be able to incorporate that into not just our next year of residency, but now actually our practice.
And I couldn't be happier to have her join me on the show, remotely, of course, to share some of the most important updates across several disciplines in neurology.
The main reason that I wanted to think about how we could find a way to go through some of these newer ideas and newer concepts that are emerging.
Welcome back to Brainwaves, a podcast obviously about neurology and medicine and all the fascinating science and history that come with it. I'm Jim Siegler, and this week on our show, since none of us are at the AAN's annual meeting, we're going to review some of the most exciting developments in neurology from the past year. Stay with us.
Sounds good. Perfect.
Hey, podcast listeners. If you're a neurology resident and you plan on taking your boards this summer, you're probably asking yourself, how should I prepare? Well, you can start by checking out the annual Penn Neurology Board Review course, now in its 17th year. This high-yield course offers a broad range of online content, live in-person or teleconference discussions, and optional mock exams with up to 1,400 questions. If you're worried about COVID-19, the course offers more than 40 hours of video-based lectures and live streaming of the 2 days of case-based discussions, all featuring experts in the field. And if you're recertifying, you're also eligible for CME credit. So take a look at all that the Penn Neurology Board Review course has to offer by clicking the link in the episode show notes or just Google Penn Neurology Board Review course. Brainwaves listeners even get a special discount on the in-person and online content. Just use the promo code WAVES2020 at checkout. That's WAVES in all caps 2020.
Again, Dr. Satyanarayan.
Ending residency with the pandemic was not part of my plan.
Still 1,000 new COVID cases every day.
It's certainly changed a lot of things. It's really brought uncertainty and fear kind of into daily life, whether it's for our loved ones, ourselves, or our patients. Our professional lives have changed drastically. Medical student clerkships have been canceled. Elective procedures are out of the question. Many outpatient resident electives have had to be replaced. But a silver lining to this pandemic is that academic institutions across the U.S., even the world, have faculty who are transforming our ability to provide virtual care with teleneurology. At Stanford, with one of my wonderful co-education co-chiefs, Amanda Sandoval, we've worked really hard to redesign our existing didactics and actually start new ones, all into virtual sessions. We have been working on finding creative ways to try to teach the subtlety of a neurological exam virtually with our faculty, and we're trying to best figure out how we can actually examine patients over the computer as well. I have co-residents who are starting online journal clubs. I know that in the broader world, we've seen a sharp rise in webinars, digital audio and video content. Even the latest social media platform, TikTok, has prompted educators to produce video tutorials. And at Stanford, we've even made our happy hours virtual.
And I think that Stanford and a lot of the West Coast institutions, like you said, you've really been pioneers in this regard. And unfortunately, in neurology, we've been very slow on the uptick as far as getting our digital educational curricula off the ground. I know the AAN's podcast was launched in 2007 by Ted Burns, and one of my friends, Andy Sutherland, has started to take over that. Neurocritical Care Society with their podcast in 2017, with Josh Levine, who was the initial host, and now Fawaz Al-Mufti. JAMA Neurology launched their podcast 2018, and only in this last year did the ANA launch their ANA Investigates with Rosamond W and the amazing host Adeline Goss. Some of these, like the AAN and JAMA Neurology and even ANA Investigates, they offer CME credit, which is honestly going to be in very high demand nowadays because we're just simply not gathering together to attend in-person lectures. So these types of resources are going to be in higher and higher demand. You know, Brainwaves is one of the smaller podcasts, but we are a strong podcast. And I'm just so glad to have you, Sammita, join me on the show today.
It's cool. Yeah. Did you just start this in residency or have you kind of?
Yeah, I started as a PGY3 in residency like 5 years ago.
Yeah. It does seem like it's an immense amount of work. I am really impressed that you do this every couple weeks.
Well, it's a fun little hobby and you've got to do something to keep sane.
That's fair. That's really fair. But cool. Well, thank you so much for letting me be a part of it. And as far as, in-person education experiences go, it's pretty hard to try to recreate a national meeting. But our senior class this year actually felt that the educational experience was really valuable to preserve. So we sat down and we actually made a mock AAN schedule with prior AAN 2019 on-demand lectures for education, review. We wanted to spend some time on scholarship and career building. That being said, the one thing that replaying older lectures can't get you is exposure to what's new. And undeniably, that's why AAN is so special. We thought it actually made sense to do a literature dive into what's been new this year in neurology. I was particularly inspired by the chair of my department, who always says neurology is a field of therapeutics, to focus specifically on emerging therapies.
For the show today, we've organized the program into 4 major categories of neurologic disease: headache, movement disorders, neuroimmunology, and vascular neurology, all featuring one important development in that respective field. So for our first topic, headache.
In the world of headache, I sometimes find myself asking, what are my abortive therapy options for migraine patients with cardiovascular disease? Triptans have been the basis of acute migraine treatment with a really strong evidence for efficacy, but it's important to talk about why we think triptans work. They are serotonin agonists, specifically primarily 5-HT1B and 5-HT1D. And they do induce a vasoconstrictor response, theoretically suppressing the well-described intracranial vasodilatory process that occurs during acute migraine attacks. There has been an evolution in understanding the pathophysiology of migraine as a more central processing disorder rather than a purely vascular phenomenon. That was led by Dr. Goadsby, who helped discover a key neuropeptide involved in migraine, calcitonin gene-related peptide, or CGRP. CGRP plays an important role in both the trigeminovascular system as well as mediating inflammation and has been an important recent target of many new monoclonal antibodies and small molecules as therapies for chronic migraine and episodic migraine. It appears that triptans, in addition to their vasoconstrictive properties, also inhibit CGRP release, raising a question of whether their vasoconstrictive properties are what's helping or whether it's something more proximal in that pathway.
So getting back to your point about the safety of inducing vasoconstriction in patients who have acute migraines, what does this mean for patients with cardiovascular disease? What do we know and what don't we know?
So all triptans have actually been seen to cause a systemic vasopressor response, so hence a longstanding contraindication to using triptans in patients with cardiovascular disease. But is that warranted? Studies have shown that this effect is greater in muscular arteries, such as the brachial or temporal arteries, rather than elastic arteries like the carotid. There have been small studies with sumatriptan, elatriptan, and naratriptan that actually show that there's no change in the coronary artery diameter. And in patients without pre-existing cardiac disease, did not significantly change myocardial perfusion via PET imaging. From long-term data on clinical trials with triptans, a majority of patients have sensations of tingling or chest pressure or tightness, but overall, there's a very rare occurrence of a true adverse cardiovascular event.
I'll jump in here and quickly echo what Sammita is saying. The risk of myocardial ischemia is very, very low, according to pooled trial and post-marketing surveillance data, while angiographic data, on the contrary, indicates that coronary arteries will narrow with triptan use. Most patients appear to experience nonspecific chest symptoms that are not actually attributable to cardiac ischemia. Furthermore, according to reliable observational data from more than 60,000 patients in the UK who were treated with the triptan, there was no association between triptan use and stroke, MI, or cardiovascular death, although providers will preferentially avoid triptan use in high-risk patients.
Which could mean people with diabetes, arrhythmia, hypertension, a history of smoking, or anybody with a family history of heart disease. So the concern that you can't extrapolate this data to patients with cardiovascular disease has persisted. This has prompted research into other serotonin agonist targets,
notably agonists to the 5-HT1D and 5-HT1F receptors, with 5-HT1F being unique in that activation of this receptor does not cause vasoconstriction.
Enter the ditans, drugs with a high affinity and high selectivity for 5-HT1F, a receptor that is working on the trigeminal system without causing vasoconstriction. Initial clinical studies showed oral lasmiditan was safe and effective to treat acute migraine. 2 large randomized placebo-controlled phase 3 trials were conducted with oral lasmiditan for acute migraine.
The first of these was published by Kuca and colleagues in 2018.
This study included patients with cardiovascular risk factors, but excluded patients with known coronary artery disease, clinically significant arrhythmia, or uncontrolled hypertension.
And if I could just jump in here real quick, that does kind of make sense. I mean, trialists will intentionally exclude these theoretically higher risk patients from drug trials in order to increase that probability of a good positive outcome.
Right. But we should continue to explore all populations in order to know who may still benefit and who's at risk. In this first trial, 78% of their patients had at least one cardiovascular risk factor. Compared to placebo, lasmiditan showed improvement with headache pain and most bothersome symptoms at 2 hours after dosing with both the 200 milligram and the 100 milligram dose. No serious treatment emergent adverse events were reported, with 36 to 42% of patients reporting at least one mild or moderate adverse events.
This study was followed up in 2019 by a second phase 3 randomized placebo-controlled trial by Dr. Goadsby and colleagues using lasmiditan,
which randomly assigned patients with migraine with or without aura to oral lasmiditan, 200 milligrams, 100 milligrams, 50 milligrams, or placebo. This trial actually did exclude patients who had diabetes with complications, such as neuropathy or nephropathy or retinopathy, significant renal hepatic impairment. However, it did include both patients with cardiovascular risk factors as well as patients with known coronary artery disease, clinically significant arrhythmia, or uncontrolled hypertension. Similar to the prior trial, this trial showed efficacy for both headache pain and most bothersome symptoms, supporting the efficacy of 5-HT1F agonists in treating acute migraine. The study noted 2 treatment-related serious adverse events amongst 2,583 patients, being a dystonic reaction and presyncope, with the incidence of cardiovascular events being very low, 0.5%, either palpitations or tachycardia. Of note, while a similar percent of patients, about 80% of their patients or so, had at least one cardiovascular risk factor, a very small portion, 6%, had an actual reported related medical history.
Dr. Satyanarayan also mentioned that, although these data from the Spartan trial by Dr. Goadsby are promising, we are still left with the question of what to do for patients in the extremes of advanced cardiovascular disease. Again, only 6% of patients had any prior cardiovascular event before they were enrolled in this trial, so it's still not perfectly clear whether that poses a real risk to these patients. That being said,
and on October 11, 2019, the FDA approved lasmiditan, the trade name Rayvow, for the use of acute migraine attacks.
Any contraindications for this drug?
Surprisingly, no. But the FDA warns against the use of lasmiditan in pregnant women due to animal data suggesting harm, and it may slow the heart rate.
Our second segment of today's program pertains to disorders of movement. Dr. Satyanarayan again.
Moving on to the world of movement disorders, there was a groundbreaking discovery in Huntington's disease in the past year, an intrathecal antisense oligonucleotide from a phase 1-2 clinical study. As we all know, Huntington's is a progressive neurodegenerative disorder caused by a trinucleotide repeat in the Huntington gene causing an abnormal protein, mutant HTT,
which builds up to toxic levels in the central nervous system, causing neuronal dysfunction and death.
Current treatments are symptomatic, and while that's important, there are currently no disease-modifying therapies. Antisense oligonucleotides have been increasingly attractive to researchers exploring genetic disease, as they can bind to messenger RNA and trigger RNase-mediated degradation of this RNA.
And in this case, you mean Huntington's disease, HTT RNA.
Exactly, which can then be degraded with an eventual reduction in the mutant huntingtin protein. And Huntington's disease is a terrific disease to study because we know the condition is inherited in an autosomal dominant fashion. We have an available test for it, and so we know who will eventually become symptomatic. Animal models showed this antisense oligonucleotide-mediated reduction as a way to lowering mutant HTT, with a sustained improvement of motor symptoms. This and other research led to a phase 1-2 clinical trial of HTT targeting with an intrathecal delivery of antisense oligonucleotides to patients with early Huntington's disease.
The Ionis HTT trial.
In this study, patients between 25 and 65 years of age with early Huntington's disease, defined by having more than 36 repeats in HTT and mild symptoms, were recruited for this double-blinded, placebo-controlled, multi-center international trial. 46 eligible patients were randomized in a 3-to-1 ratio of medication or placebo within 5 dose cohorts. All patients received 4 boluses of intrathecal injections or placebo at 4-week intervals, with CSF samples obtained before and either 4 or 8 weeks after the last dose. The primary endpoint of this trial was safety, and notably, no serious adverse events were noted in the medication groups. 83% of patients had mild reported adverse events, and 17% had moderate adverse events, most commonly being post-LP headache. A secondary outcome of CSF HTT showed a dose-dependent reduction of HTT, which we know mirrors symptom severity.
And while that's really important, we have seen similar trends in clinical trials with Alzheimer's disease, with amyloid protein reduction, without any clinically significant impact in those patients. Sammita, is there evidence that these ASOs produce any meaningful clinical change?
That is a great point. At this time, there isn't enough data to know yet. IONIS HTT was designed as a phase 1 safety study of intrathecal ASO use. In a post-hoc exploratory analysis, the investigators did observe a relationship between lower HTT protein levels and better scores on the Unified Huntington Disease Rating Scale. But ultimately, we will need these efficacy outcomes to be supported in larger clinical trials with one phase 3 clinical trial that's already enrolling.
Quickly, before I forget, how has the COVID-19 pandemic affected clinical trials in neurology and other medical disciplines?
At Stanford, I think that we've seen a pretty significant slowdown to all of our research.
And I tried to look this up too. Actually, there's no published data on how we're not publishing data, if that makes sense.
You know, I was just about to say that what I have found interesting is yes, while actually I think general neurology focused research has sort of maybe taken a slowdown, the rest of the research world at Stanford has been exploding. There's actually a great amount of work with Stanford and with, I think, the counties that are using a lot of statistical models to develop algorithms to try to predict, where people are either having symptoms or actually understand and detect the true prevalence in the communities in this area. So anecdotally, I think we have seen probably a slowdown in neurology-specific research at Stanford, like probably everywhere else in the country.
Yeah, I think that sounds about similar to what we see over at Cooper. We've seen a big shift in the number of non-COVID related projects transitioning to more COVID-related studies. Most of our trials have kind of stalled with enrollment because we have fewer nursing and research personnel on site to help out with all the various tasks and data collection that needs to get done. We have a start date coming up for one of our upcoming randomized clinical trials that's been postponed as we continue to allocate more and more resources to the care and monitoring of patients with SARS-CoV-2. And to be honest, we are trying to avoid confounding any results from these clinical trials by the unforeseeable consequences of this pandemic.
Yeah, it seems like it's a lot to consider. The timing of treatments is likely to be affected. The availability of certain imaging and diagnostic tests may be more limited, or may potentially increase the exposure of patients to testing and personnel that may be contaminated with the virus. That being said, we also don't want to deny the opportunities for these patients to receive additional interventions that could be more than the standard of care. There are a lot of interesting ethical questions and dilemmas that COVID-19's created.
Moving on to our third topic of the program, Dr. Satyanarayan chose to feature one emerging potential therapy for progressive multifocal leukoencephalopathy.
As a future MS fellow, one of the most dreaded diseases of our immunotherapies is progressive multifocal leukoencephalopathy, or PML. And one of the most heartening topics to come across is a 2019 study in the New England Journal of Medicine completed by Cortese et al., showing pembrolizumab to be a potential treatment for this rare condition. As we all know, PML is an aggressive CNS infection of glial cells seen in cellular immunodeficiencies. Programmed cell death protein 1, or PD-1, is present on T cells and is an important regulator of T cell function. PD-1 activation leads to the loss of T cell function and reduces antigen-specific responses. Blocking PD-1 can revive the T cell immune response and has been used widely in a variety of cancers. PD-1 expression was noted to be upregulated in CD4 and CD8 cells in patients with PML and is particularly enriched in the JC virus-specific CD8 cells, with a thought that perhaps this pathway was limiting the clearance of the pathogenic virus. So 8 patients were enrolled at the NIH for a compassionate use study for off-label treatment of PML with pembrolizumab. Patients received 2 mg per kilogram IV pembrolizumab every 4 to 6 weeks for a maximum of 3 doses. There was a variety of disability with patients at baseline, with 4 patients being severely disabled with a modified Rankin score of 4. The results showed 5 patients who either improved or stabilized.
And of those, all showed a reduction in the CSF JC viral load.
That was in line with the increased JC virus cellular immune response. Notably, the 2 patients who did not improve and actually died had the highest degree of viral load in the CSF and the lowest numbers of JC antigen-reactive T cells. Of the 3 patients who had no benefit, 1 had stabilized without treatment prior to pembrolizumab, and the other 2, as we said above, had actually passed away. Of course, these are small numbers with mixed results. There's no control arm, no blinding of outcome assessments. And given that all these patients had underlying immunosuppressive disease, it may not be very generalizable to our patients who have had iatrogenic immunomodulation.
Like our MS patients on natalizumab or fingolimod.
But the fact that we can modulate the adaptive immune response to treat a disease that's always been considered incurable is really very promising.
And for our last segment of the program, an update in stroke.
So in the world of stroke, everything has pretty much changed during my residency. I started off with regular stroke codes, and then came Dawn and Diffuse 3, and we switched to having extended stroke codes, and learned that maybe perfusion, not time, would be the future for stroke therapy. But I wanted to focus on something that's been a constant during residency, thrombolysis. Since 1995, alteplase has been our current standard of care of tissue plasminogen activator. As we all know, it requires a bolus and an infusion over 1 hour, which can pose some practical limitations for patients. However, at the same time that neurologists were adopting alteplase from our cardiologists, the cardiologists were already switching to a different fibrinolytic, tenecteplase. The advantage of this tissue plasminogen activator is that it can be given as just a 5-second push, which is important when you are trying to expedite thrombectomy candidates to a thrombectomy center. In one of the earliest TNK trials in cardiology, ASCENT-2, investigators found that in acute MI, TNK was associated with a similar intracranial hemorrhage risk when compared to alteplase. However, there was a significant 2.5% absolute risk reduction in major systemic bleeding with TNK. Pharmacologically, TNK has an increased specificity to fibrin with a longer half-life and more resistance to inhibition. But at the doses that have been studied in human phase 1 and 2 trials, there appears to be a similar, if not lower, risk of intracerebral hemorrhage.
And here we're referring to stroke trials using tenecteplase.
In one of the most important TNK stroke trials to date, the Extend IA TNK trial from 2018 evaluated the efficacy of TNK at 0.25 milligrams per kilogram versus standard dose alteplase at recanalizing LVO by the time of angiography for thrombectomy.
What the investigators found was impressive, and we covered the results of this trial in a previous episode of Brainwaves back in May 2018, so check out that program for all the specifics of that trial. But for the purposes today, Dr. Satyanarayan will summarize these results in brief.
Among patients with large proximal occlusions, for which TPA has been historically associated with only 7 to 11% successful early recanalization, successful recanalization at the time of first angiogram with TNK was seen in 22% of patients versus 10% of patients who received TPA. While the rate of recanalization following thrombectomy was the same in the TPA and TNK arms, at 90 days, there was a significant difference in functional outcomes, with patients who received TNK having a higher probability of independence than those who had received TPA. Again, all of these patients underwent thrombectomy anyway. It's just that those who received TNK did better in the long term. To make this TNK data more puzzling, while the Extend IA TNK trial was recruiting, the Norwegian tenecteplase stroke trial, or NORTEST, showed that 0.4 milligrams per kilogram dosing of tenecteplase was not associated with significantly different outcomes when compared to alteplase. Critics of these data highlight that a large number of patients in NORTEST had transient ischemic attacks, and most patients had mild symptoms. Therefore, any effect of thrombolysis may have been attenuated. The Extend IA TNK was quickly followed up by a Part 2, just published last year, which showed similar rates of successful reperfusion in patients with LVO using the 0.25 milligram per kilogram dosing and 0.4 milligram per kilogram dosing of TNK. When the data from Part 1 and Part 2 of the Extend IA TNK trial were combined, and in a meta-analysis published by Jeff Saver, the benefit of 0.25 milligram per kilogram TNK over TPA at improving long-term functional outcomes, according to the modified Rankin scale, has achieved statistical significance for all comers with acute stroke. This effect is likely driven by patients with severe deficits and those with large vessel occlusions. However, there's no reason why patients with milder acute stroke shouldn't benefit as well. And there are actually ongoing trials right now to study tenecteplase in patients with acute strokes who are not thrombectomy candidates.
For example, NORTEST has launched a Part 2 designed to test the 0.4 milligrams per kilogram tenecteplase dose against alteplase in patients who have moderate to severe deficits, stroke scale scores greater than 5. Then there's the ACT study, based out of Canada, randomizing acute stroke patients to the 0.25 mg per kg tenecteplase dose, and the TASTE-A trial, based out of Australia, which is testing TNK against TPA in the ambulance. So lots to look forward to in the coming months. But even though we await these better data, some of the data are already compelling enough, like Dr. Satyanarayan said, and some centers have already switched from TPA to TNK.
It actually seems like perfect timing to implement such a practice change in the era of COVID-19. Healthcare workers and nursing staff are working on skeleton crews with minimal staffing in order to reduce exposure. And we're all trying to limit the amount of time any healthcare provider needs to spend in a patient's room. So if we can keep a nurse from having to attend to a 1-hour infusion by giving a 5-second bolus, it seems like that might be helpful.
I totally agree. That was so much fun. Thanks for coming on to the show.
Awesome. It's been a great experience to be on with you, so thank you so much.
Huge thanks to Dr. Sammita Satyanarayan for joining me this week on the show and for producing an incredible mock AAN annual meeting type of podcast episode. This week's episode of the Brainwaves podcast was written by Dr. Satyanarayan and produced by Dr. Satyanarayan and myself, Jim Siegler. Our show is based out of Studio 3 in Philadelphia, Pennsylvania, with music this week courtesy of Ease Jammy Jams, Lee Rosevier, Rui, and Steve Coombs. Our theme song was produced by Timothy Dalton. Sound effects by Mike Koenig and Daniel Simeone. And remember, for those of you out there taking your neurology board exam this summer, which don't seem to be canceled yet because of coronavirus, check out the Penn Neurology Board Review course and use our promo code WAVES2020 for a discount applied at checkout. For me, it was really an amazing class to take before the boards. And for more information about what was discussed on today's program, as always, you can take a look at the show notes for the references to the highest yield literature on the topics. And follow us on Twitter at Brainwaves Audio. I'm Jim Siegler. Talk to you soon.